Hello everyone. Now I'll be discussing question on cardiology. Well, we have a 56-year-old man. He has 3 months of dyspnea, which was initially with exertion, but now it is breathless even at rest also. No chest pain, palpitation, syncope, or ankle swelling. He was smoking a pack of cigarette daily for the last 30 years. BP is 113/76, pulse tachycardia, third sound is heard, no murmur, and their bibasilar cracks are there, no evidence of ascites. The lab reports they show platelets are reduced. Leukocyte count is normal. But the value of this aspartate aminotransferase is more than alanine aminotransferase. MCV is increased. Definitely that indicate it is a macrocyte. So we are getting macrocyte, we are getting thrombocytopenia, the platelet count is reduced, and this value, this aspartate value is more than the alanine. Chest X-ray reveal cardiac enlargement is there, venous congestion is there, echocardiography shows dilated left ventricle with estimated ejection fraction of only 25%. There is no evidence of any obstruction, that means not a case of coronary artery disease. And which of the following measure will reverse this patient heart function? Well, the answer is abstinence from alcohol. Why this answer? Why not others? Well, if you look into the clinical history, he has presented with consistent with decompensated congestive heart failure due to left ventricle systolic dysfunction. What are the points in favor? Dyspnea, which was initially on exertion, and it has progressed to at rest also. He is having dyspnea. That means he is grade 4 NYHA classification. Okay. Pulse is 110. That is tachycardia is there. Third sound is there. Bibasilar crackles are there. And the most important is ejection fraction. Okay. Ejection fraction is low. Low ejection fraction of only 25%. All these parameters, they really indicate the patient has got severe congestive heart failure. Well, there is no evidence of coronary artery disease. As I told you, in angiography, total normal, there is no obstruction sees. So most likely diagnosis is dilated cardiomyopathy due to heavy alcohol consumption is the best answer in this case. Now, what are the points which are really favoring that this is an alcoholic cardiac problem? Macrocytic anemia, mean corpuscular volume is more than 100. It is 101. Okay. Thrombocytopenia is there. And as I told you, aspartate aminotransferase to alanine ratio is 2:1. This is a very important point which points toward alcoholic etiology for liver dysfunction. Now, in liver disease like viral hepatitis, alanine aminotransferase is usually more than the aspartate. But it is reversed. That means this is aspartate more than alanine is seen in two conditions. One is alcoholic liver disease. Tell me other condition where the same problem occurs. You can stop the video, write down the answer of this question quickly. The other condition where alanine transferase is more than aspartate transferase is pregnancy. So there are two conditions, alcoholic liver disease and pregnancy, where this ratio is like this, aspartate is more than alanine. Well, when we talk about alcoholic cardiomyopathy, it's a diagnosis of exclusion. Okay, we have to rule out potential causes like coronary artery disease, valvular heart disease are some of the important diseases which can lead to cardiomyopathies, and of course there are n number of other things also, but we have ruled out. So in this patient we rule out all other possibility, and finally we don't get anything. We talk about dilated cardiomyopathy. Again, it's a diagnosis of exclusion. Now, LV dysfunction in alcoholic liver disease all depends on daily amount of consumption and overall duration of consumption. In fact, alcoholic liver disease or alcoholic cardiac disease both depend on these two parameters, amount and duration. Now, the primary therapy for these, whether it is cardiac patient or liver disease patient, is total complete abstinence from alcohol. Okay, intervention is associated with the improvement or normalization of LV function over time. Now let's look into other options. Cessation of cigarette smoking. Cigarette smoking is a strong factor for coronary artery disease. Okay, now this is not, cigarette smoking is not a precipitating factor for dilated cardiomyopathy, but even a patient of DCM come to you, smoking should be encouraged to stop completely because it may aggravate the coronary problem. So the message is, carry-home message is, smoking is not a cause of dilated cardiomyopathy, but it is a cause of coronary artery disease. So cigarette smoking should be discouraged completely, but of course abstinence of alcohol is more relevant for dilated cardiomyopathy. Initiation of ACI therapy and initiation of digoxin therapy, they should be managed in the same way like any other dilated cardiomyopathy. Salt and water restriction, diuretic as needed, ACI or ARBs, beta blocker, mineralocorticoid receptor antagonist like spironolactone, or eplerenone. They are the usual drug we give, and some cases, if indicated, we can give digoxin also. Now I have a question for you. Beta blocker have been approved, but not every beta blocker have been approved. Now question is, which beta blocker have been approved for the use of in case of dilated cardiomyopathy? Quickly write down the answer in your copy. You can stop the video. Well, the answer is, we can use metoprolol, bisoprolol, carvedilol. These are some of the beta blockers which have been approved for the use of congestive heart, chronic congestive heart failure or dilated cardiomyopathy. But strict abstinence from the alcohol is the mainstay of therapy and to halt the further progression of dilated cardiomyopathy. Niacin supplement, it can occur in alcoholism, but supplementation has no role in the management of alcoholic cardiomyopathy. Now one more question, stop the video, write down the answer. Of course, niacin is used as an anti-lipid drug. Now question is, which is the most important cutaneous side effect of niacin therapy? Stop the video, write down the answer. Well, the answer is cutaneous flushing. The person feels very hot after taking this, especially in the face. Golden line to remember: complete cessation of alcohol consumption is the mainstay of therapy in patients with alcoholic cardiomyopathy. It is associated with improvement on or even normalization of the left ventricle function over time. So now you can imagine, even it can normalize the complete function of the left ventricle. So abstinence is the most important thing in the management. Well, it was regarding alcoholic cardiomyopathy, but when we talk about alcohol, and if you do not talk something shero shairi about alcohol, the lecture is incomplete. Well, those who know Hindi or Urdu, they will really enjoy it. एक शेर अर्ज है, कुछ नशा धीमी बरसात का है, कुछ नशा आपकी बात का है, कुछ नशा धीमी बरसात का है, कुछ नशा आपकी बात का है। तुम हमें यूं ही शराबी ना कहो, तुम हमें यूं ही शराबी ना कहो, ये असर मेरे दिल पर आपकी बात का है। So friends, thank you very much. I hope you like this share also. Thank you very much.